By listening to this podcast, you agree to not use this podcast as medical advice to treat any medical condition in yourself or others, including, but not limited to, patients that you are treating. Consult your own physician for any medical issues that you may be having. This entire disclaimer also applies to any guests or contributors to the podcast. Under no circumstances shall any guests or contributors to the podcast or any employees, associates, or affiliates of the Neuroendocrine Cancer Awareness Network be responsible for damages arising from use of this podcast. Welcome, everybody, to another edition of Let's Get Real with NCAN. I am your host, Mike Wayman. Today, we have Dr. Neena Vijayvergia. She's going to do a little presentation for us, but before we do that, I do have to get into a little bit of housekeeping. Our next event is going to be on April 14th in Omaha, Nebraska, our Net Patient conference, where we bring a bunch of doctors, a lot of important information, and a once-in-a-lifetime chance to really be able to sit down and interact with these doctors. We have Dr. James Howe, Dr. Sam Meir, we have Dr. Mary Maluccio moderating, and plenty more. So make sure that you sign up now. Don't wait. Go to netcancerawareness.org for more information, as well as our social medias at netcanceraware. So without further ado, here is our guest today, Dr. Neena Vijayvergia. How are you?
I'm very well. Thank you so much for having me, Mike. I really appreciate this opportunity.
Yeah, we're really excited to have you. So just real quick, can you give us a little bit of a background of where you practice? I know it's in Fox Chase Cancer Center in Philadelphia. So just give us a little bit of background of how you got into it, what you practice, and what led you to NETs.
Yeah, so I am a GI medical oncologist. I've been at Fox Chase Cancer Center in Philadelphia. It's coming up my 7th year now. My clinical practice consists predominantly of patients with neuroendocrine tumors and some colorectal cancers. It's a kind of funny story how I got into neuroendocrine tumors. When I was a fellow, my mentor at the time, he was a very smart senior physician, Dr. Paul Engstrom. He brought me into his patient's room, and he basically had a patient with neuroendocrine tumors and carcinoid syndrome, where he just pressed the area where the liver is, and then suddenly the patient's face was all red and like flushed. And that's how he showed me the whole physiology of how these tumors produce these hormones that can lead to these symptoms. And it was like seeing it happen in front of me was a very, I would probably say a awakening moment for me. And I'm like, wow, these tumors are fascinating because they not only cause, tumor related problems that they press on things in others, but they produce all these hormones that produce so many different symptoms for patients that, that's literally how I got interested in neuroendocrine tumors. And I have been doing them ever since. Since then, with the help of my mentors, my colleagues, friends, patients, I think I've learned a lot about neuroendocrine tumors, and now I do my best to help patients with it.
That's great. That's great. I love that, just that you were able to pinpoint a specific moment too.
Mm-hmm. It was a moment of awakening. The only reason I can pinpoint is because it really felt that way.
That's amazing. That's amazing. Now, in terms of like patient care and stuff like that, why is it so important for a patient to be involved with their specific treatment plan?
So I am a firm believer that, only I can be my best advocate, me or my family, right? People, no matter how hard a physician tries, a physician has 100, 200 patients that he has to care for. The patient has to care and should care for themselves. And if the patient are educated and if the patients are, leading the way in knowing what they're going through and are informed, they can actually help their providers a lot. We are humans too, and maybe a physician that you're seeing, neuroendocrine tumors are not very common. Yes, they're not extremely rare, but they're not very common either. So most physicians, there are a lot of doctors who've never seen a patient with a neuroendocrine tumor before, and they may need some guidance even from you. Like, I'm smart, we can go and read about it, but I need to know what I need to read about. So my patients help me with that. I had a patient, I actually did not know about papaya extracts having digestive enzyme potential. A patient actually taught me that, and then I researched it, and then I know all about it. So I think this is just an example of, like, everybody needs to learn more. If there's a day that you think you know everything, that's the start of your downfall, right? Yeah. So I learn everything from my patients. My patients teach me, and if my patients informed and educated, I really feel we take much better care of them in that scenario. It's like, you have two forces joined together taking care of you, not just one.
Sure, absolutely. I love that approach too. That's really important. I do think that, and the fact that you're saying to us that, hey, somebody mentioned this to me, I did my research, and it's like, yeah, I learned something from my patient. I do think that we are in an age where egos are starting to come back a little bit. I know that there was a time and a place where what the doctor said was the Bible and what you need to do and everything. But the fact that you are open to learning from your patients is huge, and it's key. And I think that's super important. And I think that's something that the NET community definitely brings to the table, as opposed to some of the other communities out there.
Agree completely. I think you learn so much from the neuroendocrine tumor patients that I am actually, like, the ideas that you get from my NET patient community, I apply to some of the other areas that I work in. I see neuroendocrine tumors. I also do some research in colorectal cancers and treat patients with that. I actually take ideas from this group, from patients, what I can do to improve, patient involvement in other areas that I work in. Just, learning from it so I can help a bigger community.
I do love that, as well as you're really approaching this with more of a humanity approach than a clinical approach, which is something that I think a lot of people, again, it's one of those things with a doctor patient relationship where if that humanity side doesn't show, it intimidates a patient. So the fact that you're willing to go ahead and do that, I love that. That's amazing.
Thank you. I hope I keep doing that.
Now, what do you think is the number one most important decision a patient can make in regards to getting proper care for NETs?
I think the major decision is you trusting your doctor, right? You're going to be in this together for the longest time. And your doctor is going to help you. At least I feel like I sort of become part of my patient's life, trying to navigate. Yes, I'm not their friend. I'm their doctor at the end of the day. But I think providing them with the truth and the right advice through this is important. And the only way what I say is going to come across, and only when I have a good relationship and a trusting relationship with my patient. So finding a doctor who you trust, who is good, who knows something about neuroendocrine tumors, but mostly someone that you trust, who you think is going to go that extra mile for you, is very important.
Absolutely. So today you've chosen to talk about clinical testing with NETs. I think that's a super important and actually a super interesting topic, to be quite honest, because knowing what you need to look out for is important. It's powerful. And you brought up earlier the NET test and stuff. I don't even think some people know that exists. So I'm really looking forward to what you're going to share with us today.
Yeah. So I made this presentation for a medical community, folks, but I'm going to try to explain it and try to move over a few slides, which I don't think we need to go into the details of. But the idea of presenting this today comes from the fact that, as you asked me, think about what you would like to speak. And I think one of the biggest questions that a lot of my patients ask me is, How often should I get my chromogranin? I didn't get my chromogranin. My urine, I didn't get my urine test done. Do I need to do that? Oh, my number is going up. Do we need to change treatment? Like, what does it really mean, and how good these tests are, and how do they help us, and do they really help us? So we're going to talk a little bit about that.
Perfect. All right. Well, the floor is yours. Here you go.
Thank you. So, I always start all my presentations. I've started with how it started and how it's going meme. So, how like many, many, many years ago, more than 100 years ago, the word carcinoid was coined to explain these unknown types of tumors that look like cancer, but they were slower growing. And now, more than 100 years later, we know so much about them that we have so many different types of neuroendocrine tumors. We don't even call them tumors. Neuroendocrine neoplasms is what they're called, and there are different versions of it. So we have made progress. The more you know, the more you can do to treat things. The same thing happened in terms of all the markers, all the tests, all the blood hormone markers we test for this cancer. So you don't need to know the names, but beginning in the 1900s and 1920s, there were two hormones that we could look for, gastrin and secretin. And now that list has, as you can see, going up and up, adding how many different things we can look for. So initially, how it started was they first found these patients who had neuroendocrine tumors, and then in their tissue, like when they took the biopsies, they found they stained that there were these special markers, the synaptophysin and chromogranin, that was higher in the cancer cells than normal cells. So then somebody came up with the idea that, if it's higher in the cancer cells, maybe it's higher in the blood too, and they started testing the blood for the chromogranin. Right now, when we look at biomarkers are basically tests or markers that help us understand how the cancer is doing. Is it doing better? Is it coming back? Is it not there? Is it there? Is it responding to treatment? All these other things. But when you look for a biomarker, we need to look for something that's really good. An ideal marker is something that can be easily obtained, that I don't need to cut you open and put you in surgery for 2 hours. It's something that's very sensitive and specific, so that if someone doesn't have it, that test's going to be negative, and you're sure it's going to be negative. And if someone has a problem, that test's going to be positive. The other is it should be simple, right? The biggest important part is it should be simple, cost effective. That I don't want to spend $100,000 on a test, which is a biomarker, because ultimately there's more things than just a biomarker that help make decision. And it should be reproducible. It shouldn't mean that I do it in one lab and it's X, and if I do it in other lab, it should be Y, and the third lab should be Z, or the marker numbers change each time, because that affects the interpretation of the results. Now, if you look at different biomarkers that we have over the years, as you can see, chromogranin A, that's the most common marker that we talk about, right? It is sensitive, like 60 to 90%, that if it is elevated, if someone has neuroendocrine tumors, there's a 60 to 90% chance that the marker will be elevated, but it's only 50% specific, which means when it is positive, 50% of the time, the patient may actually not have neuroendocrine tumor. It may be something totally different and unrelated. So that's why chromogranin, I don't think is a good screening marker for this disease, because think of it, right? If you test, and I just test it on 100 people, and 100 people have it elevated, 50 of them, it's elevated for an unknown reason, and now we commit them to all the testing and the stress of knowing that, you may have something wrong with you. It is really good if I know somebody has a tumor, and then I follow it, I check it, then that number is elevated, then you can combine them together. The other problem that comes with chromogranin is that it's not a reproducible test. One lab to the other is a different result. And because its number is affected by so many different things, foods, the use of acid-reducing medications and things like that, that it's hard to interpret the results to show a benefit. So let's say somebody got a chromogranin level checked, and then once they're on treatment for their neuroendocrine tumors, the number went up one time. Why did it go up? Was it really that the cancer is growing, or is it because there was some other reason why it went up? I had a patient who was dehydrated and their number went up. So, and that just creates angst. And I had to do like 2 different other tests. Ended up doing CT scans and imaging, and things weren't growing. So we just continued to watch them. So we ignored the test results. So if I ignore the test results, I don't like to order tests, because that just gives you anxiety. Fortunately, in our current day and age, we have really good imaging modalities. We have CT scans, we've got PET scans. There's a lot of things we have that if I'm worried that my patient's cancer is progressing, I'd rather do a scan than order this test and wait for the results. So what I'm coming to at is that in my practice, I rarely use chromogranin for making treatment decisions or for diagnosis per se. And it is a sort of a non-specific test, and most even guidelines are suggesting that it's not something we should use for making decisions. Hence, I rarely even order this test for many of my patients. The only time I order it for patients is for some reason I cannot get their scans done, and I have to do, it's a less expensive things that I'm following. But other than that, I typically don't do this test. On the other hand, look at the urine 5-HIAA test. Slightly better sensitivity of 90%, specificity is greater than 90%. So that's very important, right? It's a very specific test. So if a patient of mine comes to me with symptoms that are concerning for carcinoid diarrhea, flushing, and I test this marker and it's negative, I'm very, it's a good test saying that, something's not wrong. And if it's positive, it's a good test that something's wrong. So I feel the 5-HIA in the urine is a much better test. And if I need to follow my patients over time, this would be a better test. The problem with this test is it's very cumbersome. Got to collect urine for 24 hours, put it in your refrigerator for 24 hours. It's hard. The labs lose samples all the time. You didn't collect the bag that was to go in. So now they're coming up with alternatives, a serum 5-HIA. So they just check it in the blood. They do a blood test and check it. But that is still not widely available. It's an expensive test. And it's prospective utility, which means that, testing it in studies to see that it actually performs as well as urine 5-HIA is sort of still, out. It's still not there yet for prime time use. People use it. I've used it for a few patients, but it's not something that's routinely used. But that's the way forward. There are all these other tests, the NT-proBNP. This is for the carcinoid heart disease evaluation, very sensitive and specific test. And I'm sure when you talked about carcinoid heart disease, somebody talked to you about that test. It's a test we routinely use if you're concerned about a patient having carcinoid heart disease. And there are some other tests which tend to lack a really good data and really good sensitivity and specificity. So, chromogranin A is still the most used biomarker. Unfortunately, it does correlate that you have more higher chromogranin, they have more tumor burden, they have more disease. But unfortunately, it's not the best to reproduce, and it cannot be used to make treatment decisions, so I don't use it. There are all these other biomarkers that we talk about: pancreatic polypeptide, vasoactive intestinal peptide, glucagon, gastrin, somatostatin, bradykinin, serotonin 5-HIAA. But apart from it, the cancer cells, now we're in the day and age that we can look at DNA, not looking for proteins, but DNA. Because cancer cells secretes DNA and RNA in the bloodstream. And you can take that out and see how it's doing to see if your cancer is responding to treatment. So we just talked about these are the few tests we have. Chromogranin A, high false positive rates in proton pump use. That's like acid-reducing medicine in cancer, liver, kidney problems, etc. There's a pancreastatin. Again, it probably doesn't perform as well as our other test. This pancreatic polypeptide, it is also more prominent in the pancreatic neuroendocrine tumors, so not applicable everywhere, but there's limited studies, so I don't use this prospectively. And then there's this new test, the NET test, which looks at the DNA and RNA of the cancers in the bloodstream. And that has good metrics, but its clinical utility is still to be defined because it's very expensive and it's not available easily. So it's something that we are working on. So that is the NET test, as we talked about. What they do is they take the blood sample from you, then they take out the cancer RNA. So it's like basically how the cancer cells send signals for it. It's called RNA. It takes it out, and they make a cancer gene from it. And then they look what genes are being expressed. And then based on that, they have this whole AI-based, pipeline through which it spits out a score for you, which is the NET test risk index. You can have low, intermediate, or high risk. That is your score. What it does is it helps us decide if that score is high, the likelihood that if the patient has tumor, it's neuroendocrine is very high. So it can help you with diagnosis. In patients whose cancer has been removed, you want to wait for follow-up. It is a good test to see if the cancer is back, etc. Also, if there was a test, the diagnostic accuracy test that was done for a NET test, and it was a pretty sensitive and specific test compared to chromogranin. The problem is they compared it to chromogranin, and nobody does that. It's so bad. I would like it if they compare it to scans and say that they find cancer recurrence sooner, but we don't have those. Now, this is a test where they're basically suggesting that when they tested NET test and chromogranin levels, they actually ended up finding more patients who might benefit from treatment than not, and who should go on wait and watch based on what the score came out. So if you're high risk score, that's bad. If you're low risk score, that's good. Okay. Now, we think that the NET test is more predictive, and it's really good. But the problem is that you do not know if how effective, it is going to be. So there was one study where they compared it to CT imaging or NET PET scan and CT imaging, and they thought that the NET test could identify the cancer coming back 1 year in advance. The problem is, even if you find out 1 year in advance, what do you do about it if you cannot see it on scan? I cannot act on it. And hence, the clinical utility is very limited for this problem, for this right now. There are studies that are being done where it's been incorporated to help us identify if we can find who are the patients who needs closer surveillance or who need some treatment after the surgery. These risk scores, these are all questions in our mind that will be answered over time. But at this point, I don't think NET test is something that I use routinely for my patients. But I just thought it's something for you to know that this is where we are heading in terms of testing, moving away from just simple biomarkers and blood tests, which can be elevated in 20,000 things, to more specific tests like the NET test, which will be of the future. So this is what I have to say. At the end, I hope I talked to you something about what clinical testing in neuroendocrine tumors is. I don't know if you understood it. I think my mind was spinning more than it when I started reading about them, but I hope I was able to clarify some questions. But thank you for having me.
Awesome. I do think that it's important that we although it's not your go-to, that we know that the NET test exists. Mm-hmm. And I do think that knowing what markers are what to look out for in this space where, again, your general doctor might not know. That's why we have specialists like you come talk to us on the show. So
yeah, and I think I get a lot of concerns from patients about markers, and my marker went up a little by 100, and the patients, you lose sleep over that, and I would too if it were me. And I just want to make sure that I want to emphasize that this is a non-specific test. Imaging and doing scans is the gold standard, and it's just if it goes up, you do a scan. If that looks okay, you can rest.
Yeah.
So we think it's important that these tests come with a little caveat, and they're not just the only thing we look at.
Yes, absolutely. So, thank you so much for your presentation. Once again, everybody, thank you for joining us. Please, if you enjoy this type of content, please make sure you are liking and subscribing, sharing it to everybody in the NET community, because it's the only way we get over the algorithm, and getting over that algorithm is going to expand the world's notice of NET cancer. So please make sure you do that. Thank you so much for presenting. Follow us at netcancerawareness.org, at netcanceraware on all the social medias, and you'll find out when the next podcast is coming out or when the next event in your area is happening. And until next time, thank you guys for joining us on Nets Get Real.